Assalamu alaikum. Uzair, can you hear me?
Yes, we can hear you.
Dr. Asad, should we wait for Dr. Farooq to join or should I start?
I think आप शुरू कर दें और जो आपकी announcement है और जो introduction है वो कर दें तो we will wait.
Sure. Assalamu alaikum. My name is Kiran Amir and I'm the Director of Operations at Parsa Eco Pakistan Super Hub. Belated Eid Mubarak to everyone. I would like to welcome you all to the last ECHO session series of NAFLD ECHO. It's in collaboration with Pakistan Society of Hepatology. Today's session is NAFLD Management from Basics to Clinics, and our expert for tonight is Dr. Farooq Khan. Before I introduce to our expert for tonight's session, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation, so you can unmute yourself for question and use the raised hand option or chat box. By participating, you have given the consent for recording, and the recorded session will be available on our YouTube channel. The link will be shared by Uzair in the chat box. For CME credits, please contact Uzair, our coordinator. His number is mentioned on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity for CMEs. For the convenience of the spokes, the session is bilingual. Please speak in Urdu or English, whatever language you are comfortable in. Our expert for tonight's session is Dr. Farooq Khan, is a clinical associate professor, MBRU, and consultant in transplant, hepatology and hepatobiliary medicine, King's College Hospital, London, UAE. He is an integral part of Parsa Eco Pakistan and a passionate teacher with a special interest in providing palliative care to patients with debilitating and critical disease. I will now hand over to Dr. Asad for now.
Thank you very much, Kiran. Welcome, Farooq. It's always a pleasure and honor to you, and I can also see Professor Altaf Alam here. So I think we can wait a couple of minutes. Farooq, अभी लोग join कर रहे हैं, or you can just start with a recap of things where we are, and then you can start your formal presentation, because I'm sure there are more people joining in. So I don't want कि मैं बोलता रहूं, हम आपको सुनना चाहें और आप ही के लिए आज इकट्ठे हुए हैं. So please, Farooq, you go ahead. I think you can start at your pace then. आप muted हो, Farooq.
Can you hear me now?
Yes, we can hear you now.
Assalamu alaikum, everyone. It's always a pleasure, really. ये असद किसी न किसी बहाने से हम लोगों को इकट्ठा करते रहते हैं. That's very good. That's very nice. And it's always a pleasure to talk to you. अच्छा, एक जो चीज मैं I really want to pay my gratitude to Altaf Saab as well as Asad कि NAFLD पे teaching or training was actually long due. और हम लोग hepatitis of course is a major problem of our country. Hence we are always very focused on hepatitis management. और दूसरा ये है कि अब ऐसी दवाइयां भी आ गई हैं जो hepatitis को बिल्कुल treat कर देती हैं और अच्छा कर देती हैं. So I guess there's got to be more knowledge and insight. लेकिन I think the overgrowing concern of fatty liver is justified to have teaching and training. Or it is very, very frustrating. कोई ऐसी दवाई या ऐसी गोली नहीं है जो fatty liver को treat कर दे. And if you look around, particularly in Western countries, the fatty liver is becoming more of a reason for transplant than it was 10 years ago. Because hepatitis to treat ho raha, and that's going away. And therefore, the responsibility on your and my shoulder is extremely different to what we have before. Asad, मेरा ख्याल है अगर if you allow me, so let's just start.
Please, Farooq, go ahead.
Let me share the screen. आप लोगों को जब भी screen नजर आ जाए ना, तो फिर आप मुझे बता देना.
Yes, we can see your screen now.
Okay. So most of you by now know that I have moved to King's College with very specific aims, really, and one of the project, the target was in fact we devise a method whereby not only we can pick up fatty liver patients, but we actually tackle this. We treat this. Acha, jo treatment part hai na fatty liver ka, that is not so strong. Certainly at this stage, guidelines bhi agar aap dekh lo, or even aap agar research bhi dekh lo, we haven't quite come up with a pill jo hum le lein aur usse hamare mareez jo wo theek ho jaye. So this is an area of a lot of interest by hepatologists. So we come up with what we call King's Fatty Liver Program. What's King's Fatty Liver Program? It really is something which unites different specialities, different expertise at one platform to help patients with fatty liver, to treat patients with fatty liver. Achha. I'll talk about just very quickly introduction and some basics of anatomy. We will also discuss why is it very relevant. Risk factors are also important. एक चीज जिसपे मैं थोड़ा सा आज टाइम लगाना चाहता हूँ वो ये है कि what predicts mortality. ये वो चीज है जो आप लोगों को being doctors stress करना होगा कि अब वो जो हम पुराने methods use करते थे जिसकी वजह से हम patients की assessment properly नहीं कर पाते थे, क्या वो methods हमें आज भी चाहिए या we could actually put something in place that might help our patients earlier. Once we've done all this, then we will talk the last half of the talk really would be how do we tackle this? How do I treat this? What's the role of exercise? हम diet पे patients को सुबह शाम lecture देते हैं कि आप अपना वजन कम कर लो. What's the role? Okay, how far is the landscape for pharmacotherapy? And where does hepatology meets endoscopy? What is the role of endobariatrics in managing fatty liver? This essentially is the very major part of my fatty liver program, which we started. And lastly, surgery. Is it an option? If it's not an option, why is it not an option? And should we choose it more often than not in managing our patients? And then what I'll do, the last slide मैंने रखा है वो है, it's about just one slide पे what's our algorithm, what we use in our hospitals and in our system. Okay, just a very quick brief of anatomy. It's a very old slide. आप लोगों ने इससे पहले भी मेरे lectures में देखा होगा, but I really wanted to touch upon a very, very basic fact. There are zones 3, which is around the central vein, and there are zone 1, which is around the portal triad. Okay, the disease which affects portal triad, in diseases में LFTs बड़ी जल्दी abnormal हो जाते हैं. तो हमें जल्दी से पता लग जाता है कि हमारा मरीज जो है ना जी ये बीमार हो रहा है, ये खराब हो रहा है, and we really need to deal with it. Okay, because we call abnormal LFTs. जो मेरे colleagues आज इस talk में जो internal medicine के हैं, जो trainees हैं या जो GPs हैं, I think it's very, very relevant for them to understand that in fatty liver, the disease process is around zone 3. In patients may, we very rarely see major abnormalities in LFTs. और उसकी वजह ये है, because they are not focused or concentrated on the hepatocytes where you have very rich arterial as well as bile ducts, canal cleys. Okay, central vein का मतलब ये है कि यहाँ पे आपको abnormalities कम मिलेंगी, but unfortunately we will get the complications of cirrhosis earlier, like ascites, like portal hypertension. जब ये आपकी जो central vein है, जो outlet है आपके hepatic venous system का, when you get cirrhosis around this zone, zone 3, they get, and therefore these patients हमारी attention में उस वक्त आते हैं जब actually they have decompensated. When all of us know that this is really late, the horse is bolted now. तो हमें क्या करना है, अब कोई ऐसा सिस्टम होना चाहिए हमारे पास कि हम इन पेशेंट्स को सूनर पिक कर सकें. इज इट रियली रेलेवेंट? लेट मी टेल यू दिस इन अ मिनट. अच्छा, ये जब ईजल ने 2019 में एक पॉलिसी स्टेटमेंट दिया तो मेरे जैसे जो पागल थे, वी गॉट वॉइस who have been saying this for many years, that actually we have spent a lot more effort, a lot more time on hepatitis, and actually we now need to look at NALFD. तो in fact, अगर यहाँ पे आप लोग 20 लोग बैठे हुए हो, तो by and large 1 in 4 have got fatty liver disease, not just fatty liver. Okay, we don't know this. हम उसको टेस्ट ही नहीं करते. We don't have paradigms in the community that will pick these. And this is why I think it's important that I focus the first part of the talk कि हमारे वो लोग जो district hospitals में या वो लोग जो अपने clinics private करते हैं शाम को, how can they improve the uptake of these patients. अच्छा, ये यूरोप का है. Actually in Pakistan and in UAE is 1 in 3. So it's even more. We all know cardiac risk factors, we all know cardiovascular problems, we all know diabetes, and we all know dyslipidemia. All of this in subcontinent population is much higher. And I'm sure all of you by now know that the BMI for obesity for you and me is 27.5. It's not 30 or 31. तो हमारे थ्रेशोल्ड को भी इसीलिए लो किया गया है कि हम लोगों को ये पहले कैच किया जा सके. Okay, and why is it relevant? अच्छा, ये slide जो है ना, I would want के इसके ऊपर if I can spend only 1 minute, and this is important to understand because this is what I want you to explain to your patients. This is the natural history. This is how you and I can tell and convince our patients that what do they need to do and why do they need to do. So this is a normal liver, of course, and this you can see is a fatty liver. जिसमें you can see that the all healthy hepatic cells are now being replaced by very large fat molecule. 70% of our patients, they remain in this state and they don't start the journey forward. They live and they die with fatty liver, not because of fatty liver. 30% of ours, they really start moving forward. अच्छा, कौन है वो जो move करते हैं? 5 factors: diabetics, dyslipidemia, obese who's got overweight, we know that, people with abnormal LFTs, and people who've got fatty liver. ये 5 चीजें आप लोग थोड़ा सा ज़हन में रखना. जब they start the journey forward, it takes them about 8 to 13 years before they reach cirrhosis. अच्छा, ये बहुत relevant है. हमारे पास 28-year-old diabetic भी है, हमारे पास 27-year-old diabetic भी. So इसका मतलब ये है कि by the time he will get to 36, 37, there's a very significant chance that the poor chap will have either cirrhosis or a very late end stage fibrosis. So we need to do something about it. Okay, अगर हम NALFD का natural history trajectory देखें, तो you will be very pleased to know that 70 to 75% run isolated fatty liver. जैसे मैंने अभी आपको बताया कि 70% जो है they live happy life, they die happy life, they don't die of liver disease because of fatty liver. However, there are 25% patients who develops NASH, and there are more than 30% who develop fibrosis. अब जो आप में से थोड़े से होशियार लोग होंगे जिनका मैथ्स मेरे से बेहतर होगा, वो फौरन ये सवाल करेंगे कि ये तो जी 130% हो गया. That is not possible. This is actually very true. So there is an overlap between this and this, between this and this. So fibrosis can actually happen without NASH. और ये पॉइंट मैं चाहता हूं कि आप लोग इसको अंडरस्टैंड करो because this has got potential bearing for your patients in the future. Fibrosis can happen in your patients without having NASH, really. Okay, why is fibrosis important? A very nice review 2017, they looked at how fibrosis decides the outcome. So अब ये आप देखो कि every stage of fibrosis the mortality ratio is actually doubling up. हमें तो बताया गया था सिर्फ cirrhotics मरते हैं, हमें ये तो किसी ने नहीं बताया था कि F1 के ऊपर आपके mortality is actually almost 3, so you are 3 times more likely to die. हमें तो ये किसी ने नहीं बताया था, हमें तो सिर्फ ये बताया गया था जी जब आपको सिरोसिस होगा तो डिकम्पेंसेशन होगी, उसके बाद आपको ट्रांसप्लांट चाहिए होगा. But now the paradigm is changing because now you and I know that in fatty liver disease is actually F1 and F2. F3 can also kill you, mortality goes up. All right, let's have a look further. What about NASH? Well, NASH, of course, if it joins with fibrosis, it doubles up your risk. All right, this is important. So up आपका 28-year-old patient है, उसको F2 fibrosis, but he's also got NASH. So his years of decline has actually been reduced to 6.5. And that's very, very significant. Good news is that you and I can regress this. You and I can push NASH back to isolated fatty liver, or at least some of it can be reversed. Can be reversed fibrosis. Let me present you some data and I'll leave that to you to decide. We all by know NALFD in its own right is a disease which can cause HCC without having to cause NASH or fibrosis. So it's very, very important that we assess these patients. How do we assess? So the most important single risk factor, and I will prove it in few slides, is actually diabetes, जो हमारे मुल्क में बहुत common. So what are the then risk factors which you and I need to look after for? So age, male, ethnicity, over the age of 40, type 2 diabetes, of course, fibrosis and NASH. Okay, now very quickly, I just wanted to present you some data from Leicester, where I was when I got employed by King's for the work that I have been doing over there. अच्छा, Leicester में कुछ similarities हैं. Leicester में it was very cosmopolitan city, and we have a very, very large subcontinent population. Of course, its majority in Leicester is subcontinent population, including Gulf, GCCs, Arabic speaking, but of course, they have Caucasian. We looked at almost 350 patients, and at the referral, 10% of them were cirrhotics. So that was an eye-opener, right? We also looked at their age, and look at this. Most of the patients are actually, amongst all the cirrhotics, are the one who are at the age of 30 to 50. आपको पता है, मैं ये अपने पिछले lectures में बता चुका हूं कि अगर आप पाकिस्तान की demographics देखो, तो we are rather unfortunate country where we have 70% population is considered young than the old, but we never get to live that far. Okay, but we also looked at the BMI, and look at this. Majority of the patients who were cirrhotic were amongst the BMI of 25 to 30. Well, that's bizarre, क्योंकि अगर आप surgery के लिए भी, bariatrics के लिए भी, किसी चीज के लिए भी refer करते हो, nobody is going to refer somebody with BMI of 27. So that was an extreme eye opener. What I then did, I actually picked up those patients जो तो cirrhotics थे, either on the biopsies or on fibroscans. I said, well, let's have a look at the fibroscan scores and let's stratify them. 108 fibroscores we looked at. 45% actually had fibrosis. मैं आपको भी बता चुका हूं कि अब cirrhosis important नहीं रहा है. आज के बाद आपके और मेरे लिए fatty liver disease में cirrhosis important नहीं है. हमारी job ये है, हमने fibrosis को पकड़ना है, right? And actually almost half of the patients had fibrosis when their GP is referred to hepatologist. And out of those, 3/4, 76% have in fact high or advanced fibrosis, F2 and over, F3 and F4. तो उसमें मैंने क्या किया? I looked at the subset amongst diabetics. कि उनमें जो diabetics हैं, so 40% almost were diabetics. And the very strange finding, which I, to be honest, did not expect, कि diabetics में, for the same age and matched cohort, you can see that fibrosis were almost 60%. और जैसे जैसे stage of fibrosis ऊपर जाता जा रहा है, the severity of liver disease going up. This is age, sex, gender, all other parameters, alcohol, matched confounding factors. And as you see, कि जैसे जैसे F3 हुआ, तो आपके diabetics का somehow their severity of liver disease goes up. Similarly, F4 में भी the non-diabetic remains at the same stage. Of course, it goes up, but the difference between the two as the stage of fibrosis goes is some. So there is something that drives not the accelerated disease in diabetics, but it also drives higher intensity of. I still don't know why. I've started a study. Probably in 2 years I might know this. और दूसरी चीज जो मैं आप लोगों को फोकस करना चाहता हूं, मीन BMI जो हमारे पेशेंट्स थे, BMI of 30, and they have advanced fibrosis. Okay, so which means that in next 3 to 4 years, they likely will become cirrhotic and decompensate by 20% by the year. So these are very, very significant findings that allowed us to look at what predicts the mortality. Is it NASH? Do I really need to biopsy every patient? Does that make sense in a resource which is very limited? Pakistan ho, even UK ho, can I biopsy every patient? No, of course I can't. Well, and do I need to? Okay, almost just over 600 NALFD patients, 12.6 आप उसका follow up करते हो. Anglo have done really nice review. And if you look at the yellow line is where you have NASH positive but fibrosis negative. But as soon as you come at the red line where you have NASH plus fibrosis, as well as the green line where there is no NASH but there is fibrosis, there is not much difference. So इसका मतलब यह है कि अब मुझे और आपको बहुत ज्यादा टाइम NASH पे स्पेंड करने की जरूरत नहीं है. We don't really have to biopsy every single patient because we need to establish whether he has. As long as we have established that he has fibrosis, we could actually predict that his mortality and his outcome is going to be relatively poor. And here you guys can see, I've just drawn a graph here that as the stage of fibrosis goes up, look at the difference in mortality of your patients. Significant. किसने सोचा था कि F2 से F3 पे अगर कोई पेशेंट मेरा चला जाएगा तो he will be likely to die 3 times more likely. हमें तो सिर्फ ये बताया गया था कि जब सिरोसिस होगा तो डेथ होगी. So please bear that in mind. Why? Because ये वो patients हैं जिनके cardiovascular risk factors are extreme. So you need to understand this so to be able to deliver the right program. Okay. Now then we come to how do we tackle this. Sorry, इस पिक्चर का बिल्कुल आप लोग गलत मतलब ना लें. मैं बहुत ही गैर सियासी आदमी हूँ. I don't know how it actually reached here. All I wanted to share with you. Why me? मैं क्यों obese हुआ हूँ या मुझे क्यों fatty liver है? Let's talk about this. I want to spend some time because I want you to go and tell these to your patients. Okay, there are factors that are involved that makes them prone to fatty liver, that makes them genetically prone to have diabetes or gain weight. First is clearly hedonic drivers, clearly social pleasures. We look at things, hame halim, hame nihari, burgers, ye cheezein badi attract karti hain. And of course, nobody can deny this fact that that's really what matters. However, it's a very, very complex picture. Major role in glucose and energy, it's the gut-brain regulation. मैं ज़्यादा time इसमें spend नहीं करूँगा because previous colleagues of mine have spent a lot on this, but I want to just touch upon the gut hormones, ghrelin and GLP-1. होता क्या है? There are hedonic drivers. There's a hemostatic equilibrium जो maintained है amongst we feeling hungry and the brain telling us to eat. More important, let me take you 2 million years ago, Hispanians. आपको पता है? This is where the genetic evolutions come from. अगर आप मेरे जिन पेशेंट्स की मैं बैरियाट्रिक्स करता हूं, अगर आप उन पेशेंट से पूछो ना तो वो हर कोई आपको ये बताता है कि for the first 3 weeks I was losing weight very well, but in week 4 and week 5 I became very plateaued. I wasn't quite sure what is happening. And this is where this caveman comes in. Let me explain you this. In those many million years ago, the food was scarce. We get the food and we don't know whether for another 20 years we get it or not. So the genes were evolved and they were built in to conserve energy. They were built in to restore the basic metabolic rate will go down, and even 100 calories will be conserved by the body like anything. Okay. As we evolve over a period of time, that famine is now equal to dieting. As soon as मैं खाना कम करता हूँ, as soon as मैं weight lose करना शुरू करता हूँ, first 2-3 weeks तो चीजें ठीक रहती हैं, पर उसके बाद डॉक्टर साहब मुझे समझ नहीं आती कि मेरा weight ही कम नहीं होता, बस फिर मैं थक हार के बर्गर खाना शुरू कर देता हूँ. And that's a very common scenario. ये patient का fault नहीं है. Please try to understand this. And I want everyone to change their thought process towards obesity. इस slide को मैंने सिर्फ इसलिए present किया. We don't really need to blame our patients. If they stop losing weight, उसका मकसद ये नहीं है कि वो घर जाके निहारी खा रहे हैं और हमें बता नहीं रहे. There is a reason why it's not happening. And I can convince you even more by this very nice review, Genetic, published only 3 years ago, just in the beginning of the pandemic, really. इन्होंने क्या किया कि they looked at 1600 slim patients, BMI less than 18. Then they looked at 2000 obese patients and about 10,000 normal weight. And they've actually proven that people with obesity, they have overexpression of genes linked to becoming overweight. So please don't forget that there is a very, very significant role in genetic makeup of patients being obese in the first place, and therefore having insulin resistance in the first place, and then difficulty losing weight. And that is important factor. So, अच्छा एक question जो मेरे patients बार-बार पूछते हैं आके कि जी मैं how much do I lose? तो ये this is another important slide which I wanted to share with you all. क्या disease pattern है जो decide करता है कि कितना weight patient? The answer is of course yes. So if you really want to just treat hypertension, dyslipidemia, anywhere between 5 to 7% weight loss should really be enough, and you should see that the blood pressure starts to come down. If you really have fatty liver, but no fibrosis, then you need to lose about 10%. Females, polycystic ovarian syndrome, who aren't getting pregnant, they come for an advice. How much do we need to lose to be able to see if the fertility can be significant? Then they need to really lose about 10%. So agar ek BB ka 90 kilo weight hai, and she's got polycystic, then you will ask her really that she should be anywhere under 80 kilos. What about NASH? What about reflux? What about sleep apnea? You and me, if it's a fibrosis, then we need our patients to lose 20% and over. अच्छा इस thought को ना थोड़ी देर के लिए park कर दो कि how much do my patient they need to lose weight before we can reverse the fibrosis? A lot of studies behind this, but मेरी एक patient थी, she lost 24 kilos. She reduced her insulin, and actually at this point she doesn't use it. Her diabetes got reversed because she lost 24 kilos. So this is very, very important. Really, how much do I need to lose? Okay, role of advice. आज के बाद आपने patient को lecture नहीं देना कि आप वजन कम करो, because I've just proven you 80 studies, more than 26,000 patients. So इसको तो हम poor research analysis कह ही नहीं सकते, right? And look at this, the one factor where they just give advice only to patients, lecture देते रहे आप patients को, who have done the worst is this. So ये जो concept है, kindly इसको अपने ज़हन से निकाल दें कि अगर आप patient को हर clinic पे वो आएगा और आप हर clinic से कहेंगे कि आप वजन कम करें, आप exercise करें, आप खाना कम करें, that is not going to work, all right? And that's the only reason I showed you that. Effect of exercise on liver, fat in fatty liver. Yes, we know high intensity exercises whereby you have cardio, you have good going exercises. Yes, spinning, all these are good, and you do lose significant fat in the liver. But to be honest, हमारे patients obese होते हैं, right? They're diabetic, they're not very exercisable, they're not very active. I actually tell them, look, whatever you can do, just do it, it will work. Starting from 2009, we've lined up since 10 years of reviews and studies. I've just put all in one slide, and you can see that, and most of the work done by Kate Holsworth. She was a PhD physiotherapist from Newcastle. Significant amount of work she's done really in this field on exercise in fatty liver. And do anything what you can. This will help. Look ahead trial, very important. 16 centers with more than 5,000 patients, 10-year follow-up. Actually, this trial has actually given us a lot more insight into diabetes, weight loss. What they did, they said, we will pay the money to the GPs and they will focus on intense lifestyle and education. Just keep telling patients off every month, you need to lose, you need to lose. And look what's happened. Actually, none of them, they've lost weight, but then they gained. Lost weight, they gained. So actually none of them has lost significant and these sustained. So this trial was then stopped really. और इसमें जो मोस्ट इंपॉर्टेंट चीज आप देखो कि चाहे लेस देन 2% है, चाहे 2 to 4 है, चाहे 4, ऑलमोस्ट एवरी फर्स्ट 2 months अगर आपके पेशेंट ने वेट लूज नहीं किया है, इट्स रिगार्डलेस कि वो 2% है, 4 है या उससे ज्यादा है, ही विल पुट द वेट ऑन. सो इफ इंपॉर्टेंट पॉइंट समझने का ये कि अगर पहले 2 महीने में पेशेंट वेट लूज नहीं कर पा रहा, you need to change the strategy. That is not working, right? So we now know role of pharmacotherapy. दवाइयाँ क्या हमारे पास ऐसी गोलियां आ गई हैं जो अब हम मरीजों को दे दें और उनका फैटी लिवर ठीक हो जाए या फैटी लिवर डिजीज रिवर्स हो जाए. Okay, let's have a quick look at the landscape. Clearly the bottom line is fat ballooning, inflammation and fibrosis. And wouldn't it be amazing that we should be able to stop all of this and our patient will get better? Sadly, this doesn't happen. And there are metabolic factors. I'm not going to spend a lot of time on this cartoon, so please don't get depressed. There are really factors with FXR, the gut related, then anti-inflammatory and anti-fibrotic. Okay, EASL mein kya kehta hai? So this is very recent. I took it from EASL, and they actually says you can use vitamin E and you can use pioglitazones, but they haven't really proven much. Aur agar aap isko use karte bhi ho, to watch the LFTs, and you usually stop them in 3 to 6 months. Do I use vitamin E? Of course I do. Do I use pioglitazone? Relatively less now, but I do. But I watch their LFTs very clearly, and I don't really give them more than, particularly agar insulin resistance reverse nahi ho raha. Because what pioglitazone does is sensitize insulin sensitivity ko behtar karta hai. Okay, this slide we will spend about 2 minutes. All the pharmacotherapy, the landscape of NASH is actually on this slide. Most important, the first one really was beta-cholic acid, because the first phase 3 randomized controlled trial was available on this. The second we will talk about is LOXL2 inhibitors, then PAPAR agonists. To be honest, PAPAR agonists were the one where I, as a hepatologist, was very, very hopeful. Elafibranor as well as saroglitazars. I was very hopeful that this will work. But sadly it didn't. And then we will talk about GLP-1s, which are somewhat the major stay. So 931 patients on this, 18 months, they repeated the biopsy. Sadly, we couldn't show basic significant difference either in the NASH or in the fibrosis. What we then did, we said higher dose, and in fact, higher dose ke upar patients ko pruritus side effects zyada hue. So therefore, we're still studying it because we think there may be anti-inflammatory effect of the class genes, but I don't think we actually have anything in the market yet. So elafibranor was another one, almost 300 patients, placebo versus 52 weeks, low dose as well as high dose. And then there was NASH resolution 19 versus 9%, but there was no difference in the fibrosis really. Or May 22 studies, went into phase 3 trial, they had to be stopped because of no significant benefit on reversal of NASH or fibrosis. Oh, sorry, can you guys see me? Kisi ka gayab ho gaya screen.
Yeah, we can see you. So carry on, please. We'll mute all the participants.
Sorry.
Please do that.
Sorry. LOXL2, I never, but a lot of my colleagues felt that LOXL2 would really be the game changer. Why? Because the LOXL2 inhibitors, they really, simtuzumab, they act right the heart of fibrosis, the collagen breakdown. But unfortunately, it neither showed hepatic collagen content goes down, nor did it show that the NASH will get reversed. And actually, they stopped simtuzumab as well as elafibranor. They're not even in trials anymore. GLP-1, however, gave us a little hope. Why? It deals with dyslipidemia. Number 2, it deals with the weight loss. Number 3, cardiovascular. Number 3, chronic kidney disease. Number 5, so the benefits were endless. So this is the most studied, first by Matt Armstrong group in Birmingham, lean study, very nice placebo-controlled phase 2 study on liraglutide 1.8 milligrams they use. And the primary outcome was we want to see if there's a definite resolution of NASH with no worsening of fibrosis for 48 weeks. 26 patients, so not a huge one really, but they have shown that there is certainly reversal or NASH gets resolved, although fibrosis didn't worse, but they didn't improve it either. Then we moved on to what we called step 1, which is the semaglutide. So difference between liraglutide and semaglutide is 1 weekly. जो मेरे patients and they tolerate semaglutide much better because it's once a week. Liraglutide or Saxenda July, it's daily basis, and you have to inject. So that's really semaglutide now of tablet form. Maybe I don't know whether it's in Pakistan tablet form or not. But again, a very nice study: 2.4 milligrams semaglutide versus placebo for diet control, 500 calories plus exercise for 68 weeks. And what they have shown, they said, well, this is a positive study because 14.9% weight loss versus 2.4 on placebo. And what they've also claimed that more than 60% have lost more than 10%, which is hurrah, great. But if I can draw your attention to this, when they extended and look at the 68 weeks, look, the fibrosis is actually the gray one. And you can actually see that as we go towards a bigger weight loss, we couldn't achieve this. So yes, more than 10%, very good. But remember, हमारे patients को तो NASH है, हमें तो fibrosis है. We are looking for bigger weight loss. But that does not mean that we shouldn't use this. This is remains an option for us. Similarly, a step 4, just an extended of it where they've extended. And again, you see the same thing whereby they, as the weight loss has gone up, they really haven't achieved much of reversal. Moreover, जितना आपने उसको extend किया, उतना आपने note किया कि GI events are almost twice as common as compared to placebo. So GLP-1s have a role. We know that. It helps to reduce weight. The weight loss you achieve with this is 10% there and thereabouts. And if you're looking for higher weight loss and you want to go higher doses, the patients have higher side effects. Okay, Phil Newsome, he really looked at because he's a hepatologist, of course, with the very hepatology hat on. He looked at patients with F1 to F3 fibrosis, with or without type 2 diabetes, liver biopsy before, liver biopsy after 72 weeks. And his endpoint was also that I want to see whether the NASH resolves or not. And unfortunately, again, the same results, resolution of NASH, but no improvement on fibrosis. This, therefore, then takes us to something else. This is where hepatology meets endoscopy. And this is where most of us, I think, should really try to work on. So there are different types of balloon. Pakistan mein bhi balloons bahut zyada log use karte hain. We are very aware of this. And then there is endoscopic sleeve. We only here at King's use balloons which are either approved by NICE or FDA. And I personally use Orbera. It's 1 year, and I tell you why. So Jude Oben, my partner in crime, who really helped us significantly when about 3 years ago we started to set up this service. So Jude Oben is one of the hepatologists at Guy's and St. Thomas's who really has done significant amount of work in fatty liver with endobariatrics, and he does balloons. So most of his works were around the balloons. And what he has shown in 135 patients with BMR 41 and a metabolic syndrome of 45, so all have insulin resistance of some sort, really. He followed them up 20 months, and that's what he's shown. Not only that he has helped the BMI to go down 4, but look at this. This is the first time we have seen reversal of insulin resistance by endobariatrics. Remember, यही मैं चीज आपको जो पहले बताता था कि the hallmark is insulin resistance. This is what you and I need to look at, and actually the endobariatrics has started to just do that. ESG, how it works, surgical sleeve में वो बिल्कुल उसको काट देते हैं, they make it very small. Endoscopic में we just stitch it. Actually, here at King's, we've developed a very different technique now, and what we does, we actually leave the fundus untouched. I think I might have a video for you. Yeah, sorry, it will only take video as well. So this is Apollo. I was only trained on RX, although I do use generation 2 as well. We go down, we have a look at the stomach, we start the incisura. It's up to different, so Mayo, all these people, they do very differently. Everyone have a different technique to it. And basically what we're trying to do, this is called gastric suture gastroplasty or endoscopic sutured gastroplasty. So all we do, we basically put sutures in the stomach. It takes us around 55 minutes, depending on experience and expertise. And as you carry on doing more, clearly the time would get less. Generally, we say around 45 to 50 minutes. So we've pulled the helix in, and now we just in a moment, you'll see this is the first suture has been released. Okay. You now got the first suture. We're now just going to go into the second bit here. It's just another 30 seconds. I wanted you to watch this because I think it proves that it's very relevant that we offer these to our patients. Again, suture come in, you will feel the pop. That's the pop. That's where the suture has gone in. We'll release it, and there was the second suture. Okay, so the first suture at the top, this is the second suture. And I'll carry on down, and if I've just fast forwarded for you, and many of you would now be able to see that I've done the first line of sutures here. Okay, and as I've done the first line, we will go here and we'll start again. So it's a U that we draw and we move towards up the fundus. I've just told you we leave the fundus untouched for several reasons. एक तो उसमें complications fundus की ज़्यादा होती हैं. दूसरा, we use fundus as a camel effect. So the food gets stored there and it gives fullness to our patients. This patient, she was F3 fibrosis when we did it. It's now, I actually saw her yesterday. It's 8 weeks. When I did it, she's already lost 9 kilos. So this is, I just wanted you to see the very first suture line. If all you can see that. That's the first suture line. And we just made about 3 suture lines. She already lost 9 kilos, and you can see that her ALT from 67 has started to normalize. I'll probably fibroscan her in another month. So this was her stomach before I started doing it, and this is her stomach afterwards. And you can just see that's on the top left-hand side, there's the fundus, and she just now has a tube, which you like sleeve. Does it work? 2008 में ये data present हुआ था, and you can actually see that the weight loss, the lower the BMI, the greater is the weight loss. So limitations हैं endoscopic sleeve कि इसको ज़हन में रखें, please. You cannot deliver that service without a bariatric surgeon. But ये सिर्फ weight loss के patient हैं. जो मेरे और आपके लिए important था, वो ये था कि हमने BMI 30 को treat. BMI 30 will never be a bariatric patient. Okay, so let me go through with this program where Mayo Clinic Abu Dhabi group has really done the merit trial. Very nice, nicely done. And what they have shown, 77% of patients have lost 25%. But that's what we need, don't we? We've just talked about 20% and over. So 3/4 of the patients who receive endoscopic sleeve have really met, and the risk factors are really not there, just 2%. NALFD and ESG. I really wanted to share this last study before we conclude this. 180 patients with NALFD, hepatic steatosis, as well as a fibrosis score with very high insulin resistance. And he followed up for 2 years. He looked at 3 factors: total body weight loss, insulin resistance, and fibrosis. And look what is the first time we have seen that insulin resistance actually goes down, and clearly therefore helps the fibrosis. So I think where we need to remember things is that we need to achieve, in patients of us with fibrosis, it's about 20% weight loss that we needed to really achieve. You can combine it with GLP-1s plus endobariatrics or endobariatrics alone. This is entirely patient choice and yours. Does surgery work for them? The answer is yes, surgery achieves the maximum weight loss. On the left-hand panel, it's lower risk, right-hand higher risk, but there are limitations, particularly in our patients with liver disease. You can really see that in hospital mortality after bariatric surgery in liver patients, they really do decompensate. So just watch out as we offer to them. Despite all the benefits, only 2 to 3% patients have surgery. If you look at any world's best bariatrics program, so there is clearly a need for training and learning in endoscopic attempts to improve this really. So KFLP, this is King's Fatty Liver Program. This is the last slide. So how do we assess, how do we screen these patients? So BMI over 25 in Asian and over 27 in Caucasians. If they have abnormal LFTs or there's ultrasound evidence of fatty liver along with either they're diabetic, they have NAFLD fibrosis score more than 0.6 or indeterminate, and or they have metabolic syndrome evidence, then they really usually go down to what we call fibroscan, or they get referred to me, and we do this largely fibroscan. They get discussed in our MDTs, and these are the outcomes. So if they have no impaired fasting glucose or diabetes, no raised insulin resistance, and no fibrosis, they get managed by their internal medicine, by GPs in the community. They don't really need to see us. They don't really need anything. And you just monitor them 6 monthly with diet and lifestyle. Now, the second group is the one where they have some, but very low degree fibrosis, but they have quite raised insulin resistance and they're diabetic. They get to see my diabetes colleagues first, and or endobariatrics. If they have more than F2 fibrosis, BMI more than 30, then they really come down, and we offer them GLP-1 as well as endobariatrics. And I've shown you the two ways, either sleeve or balloon. And if they have BMI of 40, then I tend not to offer them endobariatrics. They can start GLP-1s, but they get referred for bariatric surgery. Of course, you need to be friends with them. This is the last slide, really. I finish here and I'll take questions now, please. Stop share, right?
Ji, Farooq, thank you very much for enlightening us. मैं तारीफ नहीं करूँगा, ठीक है? So I'll go straight to Altaf Alam Saab for his comments, and then we take question and answer. Ji, Altaf Saab.
Thank you very much, Farooq, for a very good talk, focusing on what we need to really look for and what we need to do, and where is the future of this problem. So certainly a lot of food for thought. We are still in a fluid state, but certainly we are getting a direction. I would just, highlight one thing here. SGLT2 inhibitors, they are pretty cheap in Pakistan. They are available, and it has shown that they not only help in weight loss, but have many good effects on the heart and kidneys as well.
Of course.
In addition to NAFLD. So GLP-1 agonists are rather expensive, so it's not everybody's can afford it, but certainly SGL2 inhibitors like empagliflozin, they are available, oral, cheap, and I would also like to mention here one approved drug in India, saroglitazar, which is PPAR gamma and alpha agonist. Again, it is only indicated in those NAFLD patients where there is diabetic dyslipidemia. The good thing about this drug is, again, the price and its oral intake. It is 1,000 Indian rupees for 1 month's treatment. So if you translate it into Pakistani rupees, it is around 2,000 or so for 1 month's treatment. So I personally feel that we are looking for an oral drug, a cheap drug. But certainly, I totally agree that there are problems with weight loss, which is the key, and endobariatrics, because surgical treatment is only indicated for a very high BMI with or without comorbidities. So there is a role for endobariatrics, and if we can develop the expertise and bring the cost down, especially in public sector hospitals, it certainly has a huge role in the future. So that's all I had to say. Thank you very much once again, Farooq. And if there are any questions or comments by my colleagues here, we would be happy to take them. We have Professor Kashif Malik. and many others. Asad?
जी sir, thank you. We'll go to Kashif Malik. Farooq, एक question है chat में. I want to know that if anyone who has fatty liver on ultrasound with F2 on fibroscan but normal LFTs, no diabetes, so can we start treatment in this patient?
Yes, of
and
course.
What is the role of statins? And
so to be honest, mera threshold statin start karne ka is extremely high. There is no randomized control trial that has proven significant benefit statins on fatty liver or reversal of fibrosis. Aapke patient ko fibrosis hai, I think, depending on whether he's high BMI or low BMI, really, if it isn't, then I will certainly give him a trial of vitamin E. Relatively less common hai कि fibrosis का reversal हो, लेकिन we certainly see steatosis का reversal. LFTs मैं आपको पहले भी कह चुका हूँ, please ignore कर दें. In patients में LFTs, they don't matter that much. And this is exactly why जब हमने ये Leicester population में study किया था, we were shocked by the fact that we were getting patient referred so late. 1 in 10 patient that gets referred to us actually has cirrhosis because people keep sitting on LFTs. And the whole idea आप लोगों को वो slide show करने का ये था कि आप लोग understand कर सको कि it's the central vein and the zone 3 which gets affected. So LFTs are really irrelevant in these group of patients.
So sir, up to what?
Sorry, Dr. Najam has a question. Dr. Nazir, I come back to you. Dr. Najam ka question and then I'll get back to you. Dr. Najam, please. आप muted हैं.
मेरे 3 छोटे सवाल हैं एज ए रेडियोलॉजिस्ट जो नाइव है और तो मेरा काफी दिनों से इंटरेस्ट इस पे डेवलप हुआ है. एक तो ये है कि यू सेड के स्क्रीनिंग के लिए फारूक आपका जो ये था कि एलएफटीज देखें एंड देन डू एन अल्ट्रासाउंड या ऑब्वियसली डायबिटिक है या फैटी. अब पॉइंट हमारे लिए जो रिपोर्टिंग सिस्टम है एज ए रेडियोलॉजिस्ट in UK, what percentage of people are actually reporting hepatic steatosis and using it as a synonym with a NALFD? दोनों के दरमियान जो डिफरेंस है और किसको ट्रिगर करना है किसको नहीं करना और इसकी ग्रेडिंग जो है S1, 2 और 3 की, how many people are actually using that in ultrasound? ये तो पहले स्क्रीनिंग के पॉइंट ऑफ व्यू से मैं बात कर रहा हूँ. फाइब्रोसिस एंड फाइब्रोस्कैन इज अ लेटर स्टेज, उस पर तो और बेताशा सवाल है. तो दूसरा ये है कि एक तो फिजियोलॉजी, कौन सी फिजियोलॉजी एज ए रेडियोलॉजिस्ट हमें करना चाहिए, बिकॉज वी आर आल्सो एट ए हब वेयर वी अप्रिशिएट कि ये S3 लेवल की फाइब्रोसिस नजर अपना फैटी चेंज नजर आ रहा है, बट देन वी नीड टू अलार्म इट इन अ वेरी कॉमन लैंग्वेज अमंगस्ट द पीपल हु आर सेंडिंग अस पेशेंट्स और रिफरिंग अस पेशेंट्स. नंबर 1. फिर दूसरा, मैं एक सवाल हर दफा कर रहा हूँ, पिछली दफा मैंने उसको क्या नाम है अमीर साहब को भी किया है सैन फ्रांसिस्को में. हमारा कोई ऐसा ट्रायल बन सकता है जिसमें हम फास्टिंग या इंटरमिटेंट फास्टिंग को बीच में डालें, बिकॉज व्हाटएवर यू से जो 3-4 पेश आए हैं इजिप्ट से पेपर्स आए हैं, फास्टिंग का जो आउटकम दिखाया है उन्होंने, इट्स जस्ट रिमार्केबल. उन्होंने बड़ी अच्छी कंट्रोल स्टडी की है, कायरो का जो लिवर स्टडी ग्रुप है. और क्या हमारे पास जो ये एक अल्लाह की तरफ से चीज है, इसको हम बिल्ट इन कर सकते हैं as an alternative या as a add-on to the medical treatment which we are offering to these patients? और क्या उस पर compliance होगी? Sorry, लंबा question.
नहीं, मैं आपके तीनों क्वेश्चन का क्विकली जवाब दे देता हूँ. So fatty liver on the ultrasound scan, we don't get our radiologist to score, or if it's fatty liver, it's fatty liver, end of. We really do not need to know कि उसका S1 है, S2 या S3 है. That's up to us hepatologists. If you have reported fatty liver and patient presented to my clinic either with abnormal LFTs और जो 4 risk factors मैंने उसमें screening tool में रखे हुए हैं, उनमें से अगर कोई भी है, what we do, जो हमारे यहाँ पे screening जो community clinics हैं, before they get referred to me in hospital, we actually offer them NALFD fibrosis scores. So and if their fibrosis scores are certainly coming, so fatty liver on the ultrasound scan is just a screening. We then do a little bit more and do NALFD fibrosis score, and based on that, we offer them fibroscan. So that's the question number 1. So steatosis S1, S2, S3, we actually do not rely at all on radiology to report it. और हमारे जो radiologist हैं वो बिल्कुल ये report भी नहीं करते हैं कि ये S1, S2 या S3 है. दूसरी चीज, अगर आप outcomes देखें ना patients की with fatty liver, actually it's not the steatosis that decides their outcomes, it's the fibrosis and or NASH. So we don't necessarily need to focus far too much on steatosis. It's the fibrosis that really decides the outcome. Last thing, aapne intermittent fasting ka, the answer is yes, intermittent fasting does help, and it certainly has a role in improvement of metabolic status, as long as jo hum logon ka problem hai, agar if you look at the cohort that you and I deal with, they actually put on weight in Ramadan because of the lifestyle that you and I have adopted culturally, proven time and time again. So the agar hum Ramadan ko actually sirf ye bana dein ki isme, हाँ, अगर आप study group करना चाहते हो and that population or the cohort that you and I are going to have are very committed, that is very different. But again, I think it's the education part of this as well. Intermittent fasting actually in UAE jo hai, Dr. Najam, it's a very common and a popular way of weight loss, believe it or not. And जब मेरे पास patients आते हैं bariatrics clinic में, तो वो आके ये मुझे बताते हैं कि we have failed intermittent fasting. So assuming, so this is, you are absolutely right. It is so popular in Gulf part of the world that patient, before they come to see me, they have assumed that he will ask about intermittent fasting and therefore we should do it. But in subcontinent population, if you look, Ramadan में तो हमारे weight बढ़ जाते हैं और diabetes भी poorly controlled हो जाती है. So it's very difficult.
वो जो स्टडीज आई है ना उन्होंने ये कहा है कि उन्होंने ओवरऑल पैरामीटर्स लिपिड प्रोफाइल पे, रीनल प्रोफाइल पे एंड लिवर प्रोफाइल पे ऑल इम्प्रूव. तो मैं ये कह रहा था कि कोई ऐसी हो सकती है कि हम कंट्रोल स्टडी इनकी कर सकते हैं. आपके पास पॉल सिद्धू है. अच्छा, प्रोफेसर साहब जो हैं वो आई एम श्योर यू आर वर्किंग विद पॉल सिद्धू रिगार्डिंग असेसमेंट फॉर लिवर. अब जो वो प्रीच कर रहा है क्या वो प्रैक्टिस भी कर रहा है?
Right. Can we move on to the next, please?
I know Paul from ages. जब मैं कहीं इसलिए मैं पूछ रहा हूँ कि he is preaching assessment of fat and diffraction and inflammation. और ये अब सारे जितनी नई मशीनें आ रही हैं अल्ट्रासाउंड की, उनमें बेसिक्स में inflammation की assessment by diffraction is now becoming a common denominator. सारी machines में आ रही.
No, true. And to be honest, I am very happy to receive as much information come from radiology. But in our pathway, we really looked at a lot of literature before we finalized, and everyone has felt that we, for now at least, will have to keep fibroscan as a relative gold standard before we offer endobariatrics, particularly our patients.
Thank you. Thank you.
Okay, thank you. एक नजीर अहमद साहब थे. सवाल, is he still there? There is a question chat में है कि what is the reason of upper abdominal pain in fatty liver? Farooq, ये काफी common है हम clinical practice में, please.
So अच्छा, so this is actually very true. अगर आप मेरी उस वाली पहली स्लाइड पे जाओगे ना जिसमें मैंने आपको दिखाया था, तो ये liver is surrounded by a capsule. Okay, जब हम weight gain करते हैं, the first organ that puts the weight on is liver. और इन पेशेंट्स को अगर आप कभी गौर से देखो इनकी सर्विस मार्किंग, या हम में से वो लोग जो EUS करते हैं, they will second me on this thing कि इनकी जो left liver lobe है, that almost reaches up to spleen. They have really large livers. There is no standard size, but they measure about 17-18 centimeters. So that the pain that is caused by fatty liver isn't actually कि वो stomach को press करन, it's the capsule pain that they get by stretching. And if you ask most of them, वो आपको बताते हैं कि जी हमें पेन ज्यादा होती है जब हम सजदे में जाते हैं या हम झुकते हैं या हमसे ना बैठा नहीं जाता डॉक्टर साहब नमाज के लिए. So that's where the diaphragm and the chest are pushing against this very blobby liver and the capsule which is stretched. So yes, you're quite right, upper abdominal pain is common. अच्छा, दूसरा अनफॉर्चुनेटली एक और चीज जो एक्चुअली आप लोग अपने पेशेंट्स को हाइटस हर्निया के लिए भी बताया करो, अगर आप खुद अपनी स्टर्नम को फील करो ना, आप जितने मर्जी मोटे हो जाओ, आपसे मुराद आप नहीं, मैं मतलब कोई भी इंसान, तो वो कभी भी अपने स्टर्नम पे फैट नहीं गेन करता, because this is the part somehow where the fat deposition is never going to happen. So where else would it go? Of course, it goes in the subcutaneous tissue that lies just between the skin and where the sternum ends. And this is where it even pushes the liver further, which is big. And also these patients get hiatus because this is what drives incompetent valve, lower esophageal sphincter. But reflux is talk for another day.
Thank you. I'll quickly go to our President of Pakistan Society of Hepatology, Kashif. Are you with us? आपके comments चाहिए. PSH is an integral part of this program.
Assalamualaikum. Thank you, Dr. Asad and Dr. Farooq. Excellent talk. मजा आ गया और बहुत कुछ हमने सीख लिया. फिर again अभी तक still we are in the phase of learning. और the good news is कि अब कोई medicines के हवाले से भी कुछ बातें शुरू हो गई. अल्ताफ साहब ने जो medicines के बारे में discuss किया, I think ये सबके लिए basically ये एक बड़ा मुफीद किस्म का lecture रहा है. और I'm sorry वैसे मैंने थोड़ा सा late join किया था because I was busy. और इसके अलावा ये है कि असद साहब very good work को जो कर रहा है इस वक्त, तो आई विल ट्राई कि आगे जो है मैं रेगुलरली अटेंड कर सकूं. कोई थोड़ी सी कमिटमेंट आ जाती है तो सम टाइम उससे प्रॉब्लम होता है. और आई थिंक कि वैसे भी मेरे ख्याल में टाइम आपका पूरा हुआ हुआ है, तो मैं यहाँ पे स्टॉप करूंगा. थैंक यू वेरी मच.
Thank you. Farooq, before we end, मैं सिर्फ आखिरी क्वेश्चन एक चैट पे आया हुआ है और उसके बाद किरण you take over. Farooq, question ये है, how long you can prescribe GLP-1? One of my patients had it for 2 years, weight loss of 40 kilogram from 180 to 140. Now we plan for bariatric surgery. Is this a good option?
So I think you've really asked a very nice question. You answered it yourself. The answer is go for bariatric surgery. 2 years maximum is enough for GLP-1s. Just for weight loss, nobody has used it longer than 2 years. People don't. 52 weeks has been used in studies, 68 weeks maximum. 2 years, hum log bhi, our program is really not that old. I must admit that we're 2 years out into it, but we don't intend to give GLP-1s for 1 year and over. Particularly जो हमारे fibrosis के patients होते हैं ना, normally मैं उनको GLP-1s, even SGL2s पे, UAE में और UK में भी sadly the law says that you cannot, if they're not diabetics, you cannot give them SGL2s. The only one which are approved for this are GLP-1s. So there's a bit of a restriction that we have. लेकिन हम normally जिनको fibrosis है, particularly F2 और F3, वो हमारे diabetologist के पास जाते हैं, वो उनको GLP-1 पे start करते हैं और first 2 to 3 months, because it improves cardiovascular status, Bina. That's what I need before I do any endobariatrics. And then month 3, month 4, then we start talking about endobariatrics. So coming back to you, 2 years is more than enough. Just offer another either bariatrics or endobariatrics. I don't know what the BMI is.
एक मैं भी सवाल एक और छोटा सा पूछ लूं. इंसिडेंस यहाँ पे यूके में कोई रिलेट हुआ है विद NAFLD एंड NASH का ऑफ HCC इंक्रीज?
Yes, 2%.
2% है, क्योंकि एशिया में इज अप टू 5%. काफी हाई है यार.
बिल्कुल होएगा, I'm sure. This is one of the reasons I was asked to move up here in this part of the world. Fatty liver is a major disaster. Is a major disaster.
यूएस में प्रेडिक्ट कर रहे हैं कि हेपेटाइटिस सी को NAFLD and NASH will take over in the next 20 years.
Oh, बिल्कुल नहीं. देखें डॉक्टर नजम, 1 in 3 तो हेपेटाइटिस है. 1 in 3 तो हेपेटाइटिस पाकिस्तान में नहीं है, right? 1 in 3 तो पाकिस्तान में हेपेटाइटिस नहीं है
जी.
लेकिन
we know that it's NAFLD is there. So it is, you're absolutely right. It is becoming far too common.
Okay, thank you. Thank you Farooq. We are 3 minutes over time और यहाँ पे एक जो burning need है, और I'm sure Pakistan Society of Hepatology और हम लोग देखेंगे कि we have to take NAFLD education further. और जिस तरह ये questions हैं, if the participants can share the questions, I think we can have at least a monthly session on NAFLD, क्योंकि this is something which is now alarming और which is और जो हमारा सबसे बड़ा challenge होगा, जबकि हेपेटाइटिस सी को हम काफ़ी हद तक मैं ये नहीं कहूँगा हमने पता कर लिया है, लेकिन at least हम उसके बारे में ज़्यादा जानते हैं. So thank you very much, Kiran. Over to you. Thank you.
Thank you, Dr. Farooq. Thanks a lot. And we are also grateful and thankful to Pakistan Society of Hepatology and Fluorescence Laboratories Limited for the unrestricted educational grant, and our team at Parsa Eco Pakistan. There is an upcoming session on World Inflammatory Bowel Disease Day on 2020 on 17th May. Uzair will share the poster for registration soon. Do join in. And Allah Hafiz from me. Uzair, you can call off the meeting.
Sure, ma'am. Allah Hafiz.